Hello, everyone. I need to be assigned the role of interpreter.
Yes,
Hi.
I'll move you to a channel now.
Yeah, the channel for Russian, please.
Are you in the channel for Russia? Thank you. Great. So I think we can start now. Or maybe should we give it another 2 minutes? All right.
Yes, please.
Can we start?
Yes, Bo.
Yes.
Greetings, everyone, and welcome. My name is Bongile, and I'm the co-ED for the Global Network of People Living with HIV. And today I'll be moderating the session for us. And we'll be hearing interesting insights from the Digital Health Rights Project findings. So really looking forward to it. GNP Plus has been involved in the work for almost 2 years now, and we've been learning so much about the digital space. So since this is Digital Week, we saw an opportunity to engage on why this is such an important conversation. I'd like to welcome everybody into this great conversation. And if you could drop your name, your city, and your country in the chat so we can see who is joining us. And for this session, we are joined by really great speakers and our colleagues from the Digital Health Rights Consortium, Mr. Dang Dong from the Vietnam Network of People Living with HIV, Ms. Tara Imelgat from the Key and Affected Populations at the Kenya Legal and Ethical Issues Network on HIV and AIDS, which is KELIN, and Ms. Irene Kopodo from the Ghana Network of People Living with HIV, and Nomtika Mdwana from the from the GNP Plus, who's also been supporting for the research in Ghana and Vietnam. For this session, we'd also like to acknowledge and thank our translators who availed themselves to support the language accessibility today. And please do excuse my pronunciation, but our translators are Tang from Vietnamese, Chantal who will be translating into French, and Carmen in Spanish, and also Dimitro who will be translating into Russian. Today's session flow, we will actually hear from our panelists on the findings from the research. We also have 4 languages for Vietnamese. Unfortunately, we do not have the correct language labeling, so please use the channel that says Chinese. And then I'd like to now then pass it to Nomtika, who will just give us an overview of the research itself. Thank you. Nomtika.
Thank you very much, Sbo, and hi, colleagues. Thank you so much for joining us today. I know it's usually a busy time for most of us, and so we really appreciate that you've made the time to join us. I think Sbo has covered a lot of just the basics of today's session, but we will essentially be sharing findings from research that we undertook in 3 countries, in Ghana, in Kenya, and in Vietnam. And GNP Plus is part of the Global Digital Health Rights Project, which has carried out this research. So I'm just trying to open up our presentation here. So here we go. So just in terms of the flow for today's session, I will be taking you through the overview of the project in itself and how we actually went about carrying out the research. And then I'm going to pass the mic to our colleague Dong from Vietnam, who's going to share very specifically research findings from Vietnam. And then our colleague Dong will pass it over to Tara, who will then share findings from Kenya, and Tara will pass it on then to Ms. Irene, who will then share findings from Ghana. Please be patient as we go through those presentations. There's lots of interesting insights. After that, we'll have a Q&A session and have a chat about the findings today. So usually how we usually start off this engagement is just by pulling from some of the frameworks that we have been using. And one of the key concepts is around data colonialism, or even digital colonialism, around a lot of big tech companies in high income countries extracting data from people and in communities in low to middle income countries. And that happens in various ways, but with the emergence of health and digital health investments and billions that have been invested in the last couple of years, there's obviously a stronger need to look at what this entails. And so the Digital Health Rights Project started this work in 2021, and we're a group of civil society and human rights organizations and academics really looking into detail around how young people specifically are affected by the emergence of digital health technologies, particularly in terms of how they access health, as well as services online, and what some of the benefits and risks are. And so the digital transformation, of course, there's a lot of opportunities with having digital technologies be used to improve access to health services. However, there's a lot of threats in that regard in terms of privacy, equality, access, and what we've just alluded to with data colonialism. And so having pandemics such as COVID that has expanded digital surveillance, and there's a lot of technology that has emerged as a result, we thought that it would be good to have a more participatory approach on how we are carrying out the study that really looks into some of these components. And again, just a little bit about the Digital Health Rights Project. We are a consortium that is made up of academics, human rights lawyers. We had started doing the project in 3 countries, implementing in 3 countries, but we've now added colleagues from BRAC University in Bangladesh, as well as Universidad dos Andes, which is in Colombia. We also do have a few other colleagues from Privacy International and Restless Development who have joined our consortium. This project focuses on the research that we had done in the initial phase of the funding. So that's why you don't necessarily see everyone here. And so just in terms of the approach, just generally around how we went about the research, we work across networks. GNP Plus, as mentioned, is working as well very closely with NEP Plus Ghana and VNP Plus. And so we undertook this approach of participatory research because we really wanted to bring more meaningful approaches to how the research for young people is carried out. So we had young people trained as research assistants. We also had young people who traveled from each of the 3 countries supporting the different research processes, but we essentially really wanted to draw from very many learnings and frameworks that exist in global health, but also specifically from the 2021 political declaration, which calls for centering communities and peer-led networks in the HIV response. And so, in addition to this, for the Digital Health Rights Group, we do have a project advisory committee that has been critical in providing insights on how we carry out the project, on some of our protocols, as well as strengthening our recommendations for advocacy. So what we were mainly looking at for this first phase, as indicated, we started in the 3 countries, which was in Ghana, in Kenya, and in Vietnam. So this particular presentation is for those 3 countries, but we do have research that's underway in Bangladesh and Colombia. And across the 5 countries, we are looking at how are new digital technologies, such as mobile apps, being piloted and used in health contexts. Looking specifically at HIV and SRHR and COVID, we looked at young community members' experience and management of the effects of digital transformation generally around their autonomy, day-to-day experiences, privacy, and then also what are the empowerment and potentials as well as risks that are linked to these new technologies. How are digital health and technologies shaping human rights norm in the pandemic present? Because obviously, being in health, just working within a health context is one thing, but if that translates to digital, which is another sensitive area, particularly for communities, it is worth looking into that. And then the last bit obviously is around governance, policymaking, decision-making on who is shaping the digital health agenda. And so these are just some of the frameworks and tools that we've been drawing some of the work from. But for example, if you look at the global strategy on digital health, there's a lot of conversation around people-centered mechanisms, programs, designs, but not a lot of those depict very thoroughly what human rights look like. Not a lot of it also mentions young people, if at all. And also the way in which digital is defined is also quite broad and not specific. So it doesn't necessarily address experiences that people might have on social media, for example, or the websites that they may visit when seeking health services. So what we as the Digital Health Rights Consortium are looking at contributing through this work is to bring human rights analysis to digital health thinking, to provide and improve young people's capacity in low and middle income countries so that we have researchers and scholars that can thoroughly look into this work as it expands. Empirical data, of course, qualitative data that's coming directly from communities to inform advocacy as well as interventions for digital health, but also having an intersectional, decolonial, and anti-oppressive framework and lens in how digital health interventions are being implemented, but also looking at existing infrastructures for national, global HIV movements to inform and engaged marginalized young people. So it is essentially to look at ways in which our own communities are affected by the shift in digital. And as you will see, a lot is going to come from that. But also, how do we then position ourselves to be able to carry out meaningful advocacy work and raise these issues with different stakeholders, high-level people, decision makers that we are wanting to engage in our advocacy. So one of the ways in which we started doing this work is mapping out what is already out there, not only in terms of interventions, but also in terms of frameworks, policy, and legal documents and approaches in each of the 3 countries. And so we worked on 3 inception papers. One was on the overall human rights framework on digital health, and it was carried out by our principal investigator, Meg Davis, and our colleagues, Nerima, Were, and Tara, who is going to be sharing with us the findings from Kenya today. And then we also worked on another inception paper that then specifically looked at the 3 countries in Ghana, Kenya, and Vietnam. And that is the paper that myself, Tara again, as well as Irene and Trang, our colleague Trang in absentia, put it together. But we've also published some publications on the BMJ And so that one is specifically focusing on participatory action research. And then the other one is looking at beyond data collection and what are some of the ethical ways in which we can improve data collection, particularly for digital health. And so following this inception process, the third piece of work that we worked on for the inception phase was around advocacy mapping. So what are the existing advocacy opportunities within the digital health context and also within the work that we already do in health as communities? And so from that inception phase, we then moved to the different data collection processes. So as mentioned, we had a cadre of young people who were trained as junior researchers. So we worked collaboratively in designing the study, implementing it, and we had a few of us travel to the different countries to support the process. We did the desk review, which was informed by a lot of work, which culminated into the inception papers. But we also did what is now what's called digital ethnography. I think for people who are familiar with research here, you know that ethnographic research is around being in the community or in the space and having the lived experience. And we did that digitally. So we sat across the 3 countries and looked at how young people, where young people and with whom young people are engaging about digital health services, information, and what the kinds of engagements are then. And then we had focus group discussions in the 3 countries in 2 to 3 districts, followed by simultaneously 2 key informant interviews, which comprised of government officials, health professionals, and other youth activists who were sharing more in depth around their experience, either in their work or as recipients when it comes to digital health. And then we analyzed the data using Deduce. I think we'll get a little bit more into that. And then following this, we then went back into the communities where we had carried out the research and then presented the findings through virtual validation meetings. And those findings informed the tightening of the recommendations thereof. So in terms of who we had, we spoke to 174 young people across 7 cities in the 3 countries. All of them between the ages of 18 to 30, as the focus is on young people. We had a varying group of individuals in the sessions: NGO staff, students, health workers, people who are peer educators, people who are within the communities and networks, people who are living with HIV, persons who are from communities who are often disenfranchised, particularly MSM, sex workers, and people who use drugs. And so it was quite a rich and engaging discussion. And those are the same people that we've sort of engaged further within the validation meetings. So I'm going to, before I hand over to Dong to take us through the actual findings from each of the countries from Vietnam, I just wanted to highlight some of the general things that have come up mostly across the 3 countries. And that it is, mobile phones and using digital can be empowering for young people, and we don't necessarily negate that. And there's a lot of, improved accessibility for them for online information. There's benefits in terms of anonymity, privacy, whether it is in groups or whether it is when engaging with health workers, they can avoid feeling judged. And then there's also an opportunity for them to find community spaces, safe spaces, and online family. And then there's risks, of course, such as misinformation and cyberbullying and most of those. And then a lot of the common apps that are used have been noted to be period tracking apps, such as Flow, which is that initial app I had shown on the initial slide, but also people generally commented on using Dr. Google as a very common platform where they find information. And then the one other key thing that we had highlighted from these findings was just around the divide across in terms of gender and geography. I think Irene will allude a lot more to that. But thinking of gender roles, family norms, socioeconomic class, education, language, ability or disability, being in rural or urban communities has huge impacts on how people access digital technologies, but also how they experience them because of the different dynamics based on these contexts. So I will pass the mic to you now, Dong, to share the findings from Vietnam. And I will ask whether you would prefer for me to continue from this or we will share your screen.
I think we can start from this. Yeah, continue with it.
Thank you, Dong.
Thank you. Thank you, Chika. Yeah. Thank you, Chika. Good morning, good afternoon, and good evening, everybody. So I would like to introduce to share some finding, the main finding from the research that we conducted in Vietnam recently. So Tika, please next slide, please. Yeah. So the research question, yeah, Tika mentioned before. So please next slide, please. Yeah, the methodology Tika also mentioned in the presentation. So please, yeah. Okay. So the next slide. Yeah. Okay. So for Vietnam, we also have some concern similar to the other countries like Ghana or Kenya. But in Vietnam, we have some specific thing that the concern focus on the information and misinformation. Yeah, and you can see here in the left of the screen, yeah, some concern about misinformation, lack of data security, and risk of exposure in Vietnam, and privacy and anonymity is the concern that we found in the research. So next slide, please. Yeah, in Vietnam, no. Can you come back? Tika, can you back?
Okay, so we're going to the previous slide. Okay, sorry, Dom. I'm just trying to check the pace here. There we go.
Yeah. So as Tika mentioned about the methodology, we have three methods that has been conducted in the research, and one of that is the interview thing. So we have key informant interview and focus group discussion. So we have 50 people with the age from 18 to 30 who involved in the focus group discussion in Hanoi and Ho Chi Minh City. These are two biggest cities in Vietnam, and most of respondents is BHIV and people from key population, and 77% of them male, and 21% is a female, and only 2% is the non-binary. And I think we think that because of the gender identity shared by group leaders, so it may not reflect the real gender identity. So and for the key informant interview, we have 15 people who come from the UN agency and government agency and healthcare worker, as well as the community leader who involved in the process for interview. Yeah. So one of the issues we found in the research is the benefits of mobile phone for health. So participants shared that the way they use mobile phone is very important to lead to the care, and participants use the phone, especially PHIV peer group. They use the phone on Zalo app. Zalo app is one kind of app look like WhatsApp, yeah, but it has been developed by Vietnamese and very popular here in Vietnam. So PHIV peer groups use the Zalo app to accept community support during the COVID-19 restriction. And the people also use the mobile phone to accept health information, especially on COVID and HIV. One of the respondents shared on the community like this: during the epidemic situation, when the whole city was isolated, I use my phone to communicate with friends, connect with community groups, And another share on the treatment. My friend participated in Zalo groups. They are sharing treatment adherence as well as sharing medicine during isolation. Yeah, that's the benefits that we found on the way that participants use mobile phone for health. So next slide, please, Tika. And another is health misinformation and data security. We found that the greatest concern were risk of misinformation and misdiagnosis. Another is fear of hacking. And we found, we know that cybersec were a health benefit, especially with COVID-19 restriction. However, cybersec raised risk of intimate photos and video shared online without consent. And one of respondents shared with us on the misinformation like this. In my opinion, now there is a lot of information and it's not verified, leading to misleading information and affecting the health of user. And another share on hacking. Someone hacked my Facebook. Yeah, it's the sad story. You know? Someone has my Facebook account to cheat money from my friend, and the police contact me. So I found that the security of information on social network is not 100% guaranteed. Until now, I'm still afraid, and they suspect me of the drug trafficking. That's one is the sharing from one of the respondent living in Ho Chi Minh City. Yeah, next slide, please. And the dependence on the phone increased during COVID is one of the issues we found. Almost participants felt dependent on their mobile phone, like emotion dependence, feeling uncomfortable with our phone. It's important for staying in touch with the family and even feeling that the phone was in control of both physical and emotion. And one of respondents share on the emotion, like, without the phone, I can't stand it. I feel uncomfortable. And for the autonomy, others share that I walk through the phone. I use the phone to communicate with a relationship. And I think the phone is also controlling a part of my health as well as my spirit. Yeah, it's the thing related to the dependent on the phones that we found from the participant. And another issue is related to the exposure, including photo, HIV status, and sexuality. So we found that the fear of exposure of sensitive photo or video and HIV status and private information such as sexuality, and when exposed to social media like Facebook or Zalo here, some participants became afraid to post online. Yeah, and it seems it's a high risk of exposure on the sensitive photo and HIV status for PHIV and LGBTQI and young women here that we found in Vietnam. One of the respondents share on the harm of exposure. I witnessed a case where young people now fell in love, also filmed a clip, and after breaking up, the boyfriend want to get back with love together, but the girlfriend refused it. And then the boyfriend posted the film clip on social media, and the girlfriend felt sad and depressed. She wanted to die, and her family and I went looking for her because we were afraid that she was about to commit suicide. It was the story that's shared by one of the respondents with and another share that I didn't know my personal information was exposed until a lot of people sent me a bad picture. And the whole morning I could not do anything. Couldn't concentrate on work. Don't understand why. Yeah, and another share on the fear. I am also afraid that my personal information will be exposed. My friend and people around me will know my HIV status. Yeah, that's the thing we found related to the harm of exposure and the fear. Yeah, so from the research we found here is one of the key findings is the innovation on the social media. So we found that the community innovation by using social media, Facebook, Zalo offer marginalized group social, psychological, and material support. So Queer and the story is one of the fan page that we observed for a long time. Yeah, so we found out it's the main channel of information, the main channel of communication that people can support other in the community. And community health workers have developed an innovative approach to communicate health information on YouTube. And Chuyện của Phong is one of the YouTube channel that we also observed for a long time and found that a lot of people has been follow this, more than 10,000 follow to receive the support from this channel. Yeah, next slide, please. And another issues in need for digital literacy and empowerment. So digital health literacy was seen as important in order to empower users to evaluate health information and protect privacy. And young LGBTQI community are said to have a more digital health literacy. And several interviewees emphasize the need on community-led mobile health apps and a platform. So one of them share on the thing on the security. Like, I think the first thing is that young people need to be trained in on knowledge and skill related to the information security. They need to know how and where to find information such as PrEP or HIV information. And another share on the community-led digital health. If the app is for the community, I would suggest that the app meets the needs of community and based on the community aspiration. Yeah, it's exactly the thing that's shared by the respondent. Yeah, next slide, please. So we have some kind of recommendation from the research. And one of this is the recommendation from participants to the government. Yeah, they want to ensure the voice of young adults and key population in digital policy in design of digital health. And they want to educate the public on their right to data protection. And they want to ensure high degree of data security for user and want to ensure the validated health information online and access to redress of harms online. So the one respondent share on the participation like this. If there is a chance that I can propose my idea to the government, I want the government to listen more, especially to young people like us. We have different needs and thoughts than 30 or 40-year-old guys. So another share that I think that groups of HIV or young KP community don't have much voice in the building health application. Yeah, and another share on the red press. First of all, I would like to change the law. Is it possible that the cybersecurity law can protect young people if they are violated or injured on the social network? There will be a law to protect them on time, in time. Yeah, so that's the recommendation from the participant. And here is the recommendation that we have from the validation meeting, because during the before we have the final report on the research, So we also have a validation meeting in Hanoi with participation of 42 people who come from the community, from the UN organization and government agency as well. So the recommendation look like the way they ask the question to the government and the stakeholder. So they want to know the way that measure how the issues have discovered affect the community, and they want to know how many key population are affected, and they want to see the comparison among the mountain and rural area and the big city, the difference between the rural area and mountain and big city, and the stigma and discrimination as well. And they recommend clearly on the way to target the cybersecurity law. Yeah, with the target audience is a government official. Yeah, it's in the recommendation, two kind of recommendation that we have from the research. So next slide, please. Oh, I think it's maybe the last slide. Yeah. So thank you. So I would like to pass the microphone to Tara, our colleague, who will presenting the finding from Kenya. Yeah, thank you.
Thank you so much, Dong. I think I'll just share my screen and share the presentation. Let's see. All right, so good afternoon, everyone. My name is Tara Mangat from the Kenya Legal and Ethical Issues Network for HIV and AIDS, which is based in Kenya. And I will be sharing the findings we had during the digital health and rights research that was carried out all throughout last year. So in Kenya, like in Vietnam, we did see a high dependence on mobile phones being a hot topic. Information and misinformation was also discussed, privacy and anonymity, as well as stigma and discrimination. But for us, what we did see to a large extent were the gender differences in the use of digital technologies. For instance, we noted that men are actually more involved in the use of digital technologies within the health sector. But then when it comes to users of digital health applications, women are actually looking for health information a lot more than men, who mostly prefer to utilize their mobile phones or the internet for entertainment purposes. So just to expound a bit more about the dependence on phones, similar to what Dong had mentioned about Vietnam, many young people described a high dependence of on mobile phones. Even talking about how this had become an addiction. And you can see here one excerpt says that without the phone, you are like nothing. So we did hear some concerns about this dependence on mobile phones, particularly since the onset of the COVID-19 pandemic. And this, of course, brought about a discussion on mental health and how our continued use and dependence on mobile phones for daily life could in fact create mental health issues and implications. So that was definitely a hot topic, but of course we do know that there are benefits to ease of access to mobile phones, but of course we cannot talk about the benefits without the drawbacks. So this was both a positive and a negative finding. So with respect to accessing of health information, we did note that women do often look for sexual reproductive health information on HIV, COVID-19, menstrual health, pregnancy, contraception, access to safe abortion, which is of course a hot topic, as well as mental health online. We did find that men were less likely to look up health information. As I'd stated, they would much preferred to use their phones or the internet for entertainment purposes. But also, they did highlight the fact that they felt that most health apps were targeted towards women. And in fact, in Kenya, most of the health apps we did find were, as Nomtik had mentioned, to do with pregnancy tracking or period tracking. So that could be true, and it's something we did feel like we will need to raise as we continue disseminating these findings. So Tika did mention Dr. Google, and yes, that is something that our participants highlighted, that they preferred using Dr. Google as well as social media, particularly social media influencers, to access this health information. Very few participants used mobile apps or are aware of any mobile apps that were in existence that they could access in Kenya. So that is something we did note. And I think generally speaking, there was a sense that the use of technologies to access information or services provides a safe space. And they did feel like that created some anonymity. For example, we have an excerpt here where one of the participants states that, I think I can use my phone without being judged. Like I can access some information without worrying about someone noticing. So that definitely highlights that safe space that some of these participants experience. And then with respect to men accessing health information, we did hear one or two men talk about the fact that they needed to rely on the internet or social media to obtain information on mental health. And we have someone here who had stated that we all must agree that during the COVID period, many people had mental issues and some of them ended up killing themselves. I can say a mental health app really helped me when it comes to deciding some stuff. So that shows you that there is a gap and that both men and women are in need of specific targeted mobile applications for their health needs. So with respect to access, once again, we did highlight that there was a big digital divide. So for us, because our focus was around mobile applications to do with sexual and reproductive health, we did talk to predominantly a large group of women, but majority of them did share that they had issues being able to access smartphones or even the data that's required to access the internet to access these applications. So that was noted, and this was a concern higher in Kisumu, one of the counties we did conduct our research, because in terms of socioeconomic background and the difficulties with access to education in Kisumu compared to Nairobi, the cost of actually buying these smartphones was deemed an issue. Other issues we found were with respect to the lack of internet, particularly within rural areas. And that's why we have a quote by one of the participants who was basically asking that data be made free. So they stated that, I'm also thinking the government should partner with Safaricom so that I wouldn't be paying to get health information. So there's that demand for low cost of data or free data so that most people can access it with ease and without any issues. We found that particularly in Kisumu, but also in Nairobi, because of the issues with data, many young people were relying on hotlines where they could call in and talk to a healthcare worker about the issues they're facing, about the need for health services. So that was actually a preferred form of access. And this was only because this was the cheaper way to actually access that information without having to spend money on data. Some of the participants also talked about the need for diverse languages within these health applications. Someone here said that our government is passing information in a very comprehensive manner and forgetting about me. I will read English, I'm literate, but John in the neighborhood doesn't understand English. So that, of course, speaks to ensuring that local languages are incorporated in the development of these health applications and technologies. They also were very keen on ensuring that people with disabilities and different groups, such as the older generation, are not left out, and that the apps are disability friendly or are easy to use, so that different groups are not left out of the digital transformation that's happening at a rapid pace right now. In terms of the risks online, we did hear about some people talking about how they would try and share some sexual and reproductive health information online, but their posts would be taken down. Others shared concerns with respect to data mining and privacy. And some, highlighted the fact that people may expose you, online. So they prefer to go to Google where they're anonymous. And then we also heard about concerns about misdiagnosis, and that's a big one. And we hear from one of the participants who said, we have decided to be our own doctors. Like, you end up treating yourself and it is the wrong thing that you are treating. So that is a big concern. If there's no trust in the healthcare services and provisions and the provision of those healthcare services, then of course people will turn to the online spaces, and the information online may not be accurate. And we did hear about cases where some of the participants actually went as far as to buy medication and to suffer the consequences of reactions because that was the wrong medication to take. So online interaction does have a direct impact on offline well-being. So that's something we definitely noted. Like Dong had mentioned, in Kenya, we did see some cyberbullying. In fact, 73% of the women we interviewed spoke about cyberbullying. Of note, we did hear about trolling. Someone said that I once championed against sexual and gender-based violence. They bullied me, and they said that they would come for me. I was scared out of my mind. Of course, the LGBTQ plus community also disproportionately is affected by trolling. We hear that one of the participants stated that that some of the people who saw her post actually came for her family. So that's troubling. We heard of instances where people were being silenced, so basically harassed and bullied out of these different platforms. And of course, sexual harassment, where women stated ignoring men and then receiving lots of harassment because they were not doing as they were required or requested to. So these are sort of the issues we did hear about from our participants. And then something that we did note was the issue of the lack of redress. We did feel that there was a sense of hopelessness once we did talk about some of these things with respect to what happens if my privacy is breached, what happens if someone harasses me, where's the justice? So this lack of redress was in particularly an issue of concern, especially for young sex workers that we did get the opportunity to speak to, who talked about how they shifted to online platforms during COVID, and they would of course share some of their pictures and videos, and in some cases they were forced into blackmail. So this is worrying, and it is something that we've definitely addressed as one of our recommendations to improve and increase the reporting mechanisms within these online platforms, and to ensure there's accountability mechanisms in place for these kinds of things. So in terms of innovations, during our digital ethnography, and I believe that Nomtika alluded to some of the work we've done, where we basically went and observed what young people are talking about on online spaces. We did find a website called Love Matters, which is on Facebook, and they have attracted millions and millions of young followers, and they really have tailored their messaging to be relatable to young people with pictures. And they've created a space for young people, including LGBTQ plus communities, to share in this knowledge and to converse with each other. So that's been amazing. We also found a blog/vlog called Spreadpod. Sex positive and the woman who runs it really ensured that it's a space where not only young people can get information about their sexuality, about reproductive health, but also she offers training to parents about how to go about having those conversations with the young children. We also saw community support groups online. And for example, I'll just give a quote, which is on the right here, that we have a WhatsApp psychosocial support group. An online moderator who is a peer educator, a young person, brings in clinicians who come and talk on a specific topic. So you can access the correct information as well as referrals. So that just shows you how during COVID, people found ways to still ensure that this information, useful information to ensure that their sexual and reproductive health is protected, is being shared as much as possible. So we did see an increase in support groups. We also saw some very creative innovations, for example, by sex workers who said that they had developed a murder monitoring tool where they would report cases of murder and cases of violence on their fellow sex workers. So that again shows you that people will find a way no matter what, and digital means is where we're headed. So I think this shows you how much potential there is in Kenya in terms of how to ensure that this information and services are brought to young people in very innovative ways. So in terms of recommendations, what stood out to us was, of course, that our FGD participants did express a strong desire for privacy and confidentiality online. Majority of them wanted health apps that would actually link them to trusted counselors and services in person, which is similar to what Dong had shared. And they did also call for more youth participation in digital and data protection policies and more sexual and reproductive health education in schools, which is something that is a very contentious issue in Kenya, and it's been disallowed in our educational system. So that's something they did believe would be a very useful tool to ensure that this education is shared from a very young age. And of course, they wanted there to be a use of USSD so that those without smartphones can still access useful information or referrals to friendly health services. So I'll just read just one or two of the quotes here. The government should acknowledge and appreciate that young people exist in different diversities and they have different specific community health needs which need to be met, because it's stipulated in the Constitution that everyone has a right to access to quality health. We also have someone here who said the government should invest in digital safety workshops, and another person who had said that what I would tell them is that they should be completely honest with me. Tell me this is how we're going to use your data, and are you okay with that? So this just basically highlights and brings to life these recommendations that we thought really stood out. Also, I'll just quickly go through some of the specific recommendations that we found and discussed with our participants and we came up with. The first is to the government, and we're asking for more youthful, meaningful youth engagement in the design and implementation of these health apps, sites and technologies, as well as in the development of these digital and data laws and policies. We'd like them to partner with private sector providers to promote access to free and low-cost data. We'd like them to scale up locally developed applications and support local pilots developed through grassroots innovation, because we did find that there were some health applications that were developed, but unfortunately they were discontinued in their infancy due to a lack of funding or support. We'd also like the government to increase investments in the tech infrastructure and also in digital literacy and data protection regulation and awareness. And of course, we'd like them to create an enabling legal environment so that the laws that are passed are rights-based and that there's proper implementation of these laws. To the civil society and the media, we ask for there to be more involvement with respect to the provision of digital literacy training and mobilization of young people and activists to hold the government and the private sector accountable for the way in which they're developing these interventions and enforcing the laws in place. And of course, we want the media to create safe platforms for young people to share their experiences, engaging digital technologies, and to raise awareness on digital rights, as well as to highlight the gaps in regulation. To the private sector, we'd like them to develop user-friendly and responsive applications that have simple language, includes local and native languages, child-friendly, and person-centered. Of course, for that to be disability-friendly applications, even audio options if possible. And application should also include accurate and contextualized information that's reflective of what the communities are going through, because we found that there were some apps that were being used, but these were developed in the West, and a lot of the young people felt like they couldn't connect with the information being shared, and so they felt like there needs to be more apps that really reflect what they're going through. Of course, we want apps that link young people to friendly service providers, especially for the LGBTQ+ communities who struggle to find safe health facilities to access health services. We would like more transparency with respect to the use of personal health data, as well as feedback mechanisms in place. And then to the international community, we felt like there should be a promotion of rights-based approaches to the use of digital technologies, a documentation of good practices, including social media, which we found was really drawing a big crowd and really needs to be investigated further. And we'd like them to work with our governments to ensure that the digital governance is not only rights-based, but also it integrates health issues, because our digital governance is to an extent strong, but it does not translate when it comes to digital health as a whole. So I think I will close and just pass the mic to Irene to share the findings from Ghana. Thank you.
Okay, thank you so much, Tara, for passing the mic. So if I could have the presentation for Ghana. Thank you. So I'll be speaking to the findings from Ghana. In Ghana, we were the study was conducted in 3 zones: the southern zone, the middle zone, and then the northern zone. And specifically, Ghana focused on the digital divide. For some of the research questions, we looked at how young community members experienced or managed the effects of digital technologies on equity, autonomy, privacy, and equality. And then we also asked young people who they thought or who they felt was driving the digital governance. Next slide. So in Ghana, we had 56 participants, also in the age range 18 to 30. Majority of our participants were male, and we had 2 sessions with PLHIV groups of young people. We had one group for MSMs, one group which was for sex workers, and then we also had key informant sessions with government officials, UN officials, and then some other NGOs or CBOs that we worked with. Next slide. So as in the other 2 countries, Ghana also highlighted, the study highlighted tendency of mobile phones, particularly for our respondents. There was breach of privacy and anonymity, and there was stigma and discrimination, as well as abuse of some of the respondents. And there was information and misinformation from the findings. And then also we had peer support and community information sharing amongst the participants from the study. Slide. For Ghana, these are the specific questions. One of the specific questions we asked the respondents. We asked if they felt that their phones controlled them. And some of the responses were that there was high degree of dependency on their mobile phones. Some participants actually expressed that they felt that mobile phones were controlling them. And then others also tried to see how best could reduce dependency on the mobile phones because it was taking majority of their productive time. And then others also indicated that during the COVID-19 period, a lot of them used mobile phone for work, for school education, and then entertainment. Then also indicated that they use their mobile phone for business or trading. And then some excerpts from those discussions that I get so attached to my phone that I forget to eat. Another person also indicated that personally, I ask myself, why am I in the middle of something important, but I feel the urge to check my phone? Next slide. Another question we asked respondents is privacy important to you? This is in relation to their use of their mobile phones. And then majority of them indicate that they had a strong preference to get health information online because it was anonymous. Participants indicated that for them, it was better to access health information online because you don't get to receive backlashes from health service providers, because when you go to facilities in person, if you are from a minority group or a key population group, you are judged, or condemned. And so they felt safer to rather go to social media or online to find information regarding their health, where whoever was providing the service to them didn't get to see them and judge them. And for the MSM and the sex workers particularly, they indicated that it was unsafe for them to go out or meet in public, and felt it was easier and better for them to meet and engage people online. And in one of the discussions, participants, previous slide please, yes. One of the participants indicated that they experienced stigma in clinics. And so when they go to these clinics, and then they share their story or the reason why they're coming to the health facility for that service, the person indicated that I am this way and that, and I had sex and I feel this kind of way. And then she's going to ask you, where, what kind of sex and all that. And sometimes because a lot of young people do not feel comfortable talking about their sexual lives or experiences, and because they are going to be judged, they prefer not to share some of these information. Meanwhile, if they are able to share some of this information, it would help the healthcare provider provide the best care and treatment of that person. But because they fear that they might be judged or chastised, they would rather go on to social media or go online and then get information from there. Next slide, please. Now, we also highlighted different experiences based on the two, the study from the participants. We segregated male and female, and these were some of the experiences male participants shared. Our male participants indicated that mostly they go onto Google or social media, which is Facebook or WhatsApp, to find information or data relating to health and their well-being. And they were also less likely to search for health information regarding their own well-being when it comes to our male respondents. One person indicated that I have received numerous health tips because I have a WhatsApp contact, and said, hey, this is the situation. How do I go about this? Then somebody says, okay, doing ABCD will help. For our women or female participants, they indicated that they used peer-to-peer advice. So they reached out to their peers whom they were comfortable with, or went on social media or other mobile apps to get information, or they used hotlines to reach out for health education or health information. One person indicated that I was interacting with other young people and I wanted to share some health information based on certain experiences they shared. but I had no data. I couldn't access it. So it goes back to tell us the digital divide, and that the women or young girls find it difficult to access data, to be able to get health information as and when they need, just like Tara indicated was the issue in Kenya. Now, specifically regarding the digital gender divide, we realized that there were a lot of young people, the inability to afford smartphones. Most of them probably had feature phones that they used in communicating or providing information. And then there was also the less ability to afford the cost of data. Respondents also indicated that there was less knowledge on how to protect themselves about stalking, hacking, or harassment. And this was particularly with the MSM group as well as the FSW group. And then some participants also indicated that there was less access due to family or religious environments. And this was particularly dominant in the northern parts of the country, where some respondents share that they shared their phones, particularly young girls shared their phones. And so when they needed to search for information regarding their health, particularly sexual or reproductive health, they needed information from, or they had to use their parents' phones, their mother's phones. And so it was very difficult for them to, search for very specific information because it wasn't their personal or private phones. And young LGBT people, especially MSM, had more digital literacy and confidence than other FGD participants. And this was evident in the Accra and the Kumasi FGD sessions. And also female sex workers were more likely to share phones and less aware that they could use them for health information and services. FSW participants mentioned that they didn't know that they could access health information. And so for them, if they had issues regarding health or their well-being, they were more inclined to reaching out to their peers or trying some local remedies or concoctions to get better or get well. Next slide, please. So these were some of the risks respondents indicated that they encountered online. Some indicated that there were reports of blackmail, extortion, and violence against the MSM and sex workers community. Some also indicated that they were bullied, cyberbullied. They were stereotyped and harassed, especially on Facebook. And then another person also indicated that there was misinformation regarding HIV cures. So some specific comments, excerpts from our respondents were: one, regarding misdiagnosis. The person is said, because of the stigma, because of this belief that I'll be stigmatized, PLHIV, avoid clinics. Rather, go online and then seek information on self-treatment, self-medication, which doesn't help. I see it to be very risky. There are all sorts of quack doctors out there telling you that I can cure you. And so they expect that you come to them for treatment services or cure regarding HIV. And then also some mentioned abuse specifically. One person said, so you would find someone who are imposters, not part of the MSM community, but know the apps we use. Then they arrange for hookups and you are kidnapped, you are blackmailed, you are abused, you are physically and emotionally abused, and it has a lot of impact on their well-being as well as mental health. And so those were some of the excerpts from respondents who faced bullying and harassment. Next slide. For vulnerable communities, most of them use social media to meet and And so vulnerable communities, including the MSM community, the FSW community. And so they prefer to use social media to meet and share health information. And they provide some form of training to their peers so they're able to detect who is actually a community member and who is not. And then also they provide SRH services to their groups. Some have WhatsApp groups or Facebook groups where they provide learning information about SRH. And then some also patronize USSD codes, short messaging codes, to different applications that civil society organizations or government institutions use to provide health information and education. And then there are also adolescent peer educators who have specific hotlines to provide SRH services. For one civil society SRH app, which is called She Plus, the respondent indicated that they have different languages, and before a client calls, they already know the language the client is comfortable speaking with. And so they assign someone who is able to interact with the person in the language the person is comfortable with, so that they could provide the best services to the clients regarding his or her issue. Next slide. Now for the recommendations. For the national level body, young people recommended that there was no organization specifically tasked to host applications, digital health applications, and so they would appreciate it, or would rather there is a body, either a government body or maybe a civil society body, that hosts all digital health applications, scrutinizes it, and ensures that information on these digital health apps are accurate, and then providing quality and timely services regarding their health issues or health information. Young people also said that they would want to ensure that the voices of youth and community members in the e-health strategy and policies that was developed are featured, so that young people's needs are captured in the development of these documents, so that we would have infrastructure as well as implementation and regulation of these policies that are tailor-made to suit the specific needs of young people. And then young people also recommended that there's an integrated pilot and anonymized. Then also there's the need to ensure equal access to health information and services through data bundles, phones, USSD lines, and digital health tools in all languages, just like the She example, the She Plus example I indicate. I think across the 3 countries, you realize that young people are advocating or recommending that data cost is reduced, or even given to young people regarding their health for free, so that they could make better and informed quality decisions and choices when it comes to their health. And also, young people recommended that when it comes to the use of social media, a lot of young people find it easy to get to social media or reach out to social media for health information. So they indicated that they would want social media or applications that provide health information to be user-friendly. The visuals that these social media platforms project should be appealing to them in terms of language, diction, and also it should be able to link them to the specific services that they need. And then finally, the last recommendation is to ensure that we have a system to report health information. So if there's a blackmail, there's an abuse, there's violence, there's trolling of any young person regarding their health or their well-being, there should be a system, a reporting system And this reporting system should be an effective one that ensures that there's timely redress. So when the young people report their issues based on blackmail or abuse, they get justice served and in a timely manner. So those are some of the recommendations that came from our research. I'll pass over the mic to Nomtika to do the next steps. Thank you.
Thanks, Irene. I'll be very brief since it's on this slide. I know we have this coming up, Sbo. Maybe we'll elaborate more on the UNSR later. But just to really thank all the three presenters, firstly, just as having been part of the project, but also to acknowledge our colleague Trang Pham, who has worked with Dong tirelessly on the project and has contributed quite greatly. So who's been involved in the research study. So at the moment, through the same lens, we still have the studies ongoing in Bangladesh and Colombia, but also from these findings that we've just shared with you, a lot of work has come up, and part of it is developing a series of articles and a policy brief. We are going to launch these findings and the entire sort of overview of the project in November at a side event. We also have a digital literacy resource that we have developed, which I will share about later, that we will later be able to access as a network and a community for us to equip ourselves with this knowledge, but also use it to train others. And through that, we've received a series of ways in which that project can be supported. But also the UN Special Rapporteur on the Right to Health is looking at digital technologies next year. And we've also had some consultations and are working towards a submission for that. Thank you so much. Sbo, I think we'll pass the mic back to you.
Thank you. Thank you to the speakers and to you, Nomtika. Really interesting conversations around digital use. I was particularly moved to see that young people are really accessing like information, particularly health information, and therefore there's a need for greater capacity on that space, and there's a need for issues like to protect them on that space. I'm just going to take a few questions, but we will start with looking at, there has been questions directed to each speaker on the chat room. I'll start with the question for Tara. In Kenya, do you think that health applications via mobile phones are actually a good way to share health information? Are health apps worth the effort? Tara, do you want to respond to that before I move to another one?
Yeah, sure. So thank you for the question. I think it would depend on the app, because a lot of people do find health apps convenient, for example, period tracking apps. But I think for people to really turn to health apps for health information instead of Google or other tech platforms, then it needs to be an app that meets certain criteria. For example, it would need to be inclusive, it would need to have information that's up to date. The information will also have to be contextually relevant, and all these kinds of things. It would need to be easy to use. It would need to, there would need to be ease of access for different groups of people, protection of privacy and data. So I think there's a lot to consider. I think that health apps do have a potential to be a really great resource, but I think it all boils down to how well the app is developed, and whether people have been placed at the center of that development and deployment of those apps. So that's what I would say. Yeah.
Thank you, Tara. The next question is directed at you, Irene. How do we control health information if the source is Dr. Google, taking into consideration that everything is available on Google?
Okay, thank you. Now, with regards to information that is on Google, we know that about 80 to 90% information on Google is true, but depending on the specific information that a young person may want, if Google is not able to provide that unique information, then the young person might be forced to look out for other sources which may not be regulated and so cannot be vouched for in terms of the quality or the facts that the site might be providing. So for young people, I would recommend that, yes, you could use Google, you could use other health applications that you have, but it would be good to find 1 or 2 trusted people, paramedics, who can provide very, very factual information in a non-judgmental atmosphere. Thank you.
Thank you, Irene. We have a question in French. So Chantal, if you could translate that, if you could translate the question for us, that would be great. Do we have Chantal?
I
People
can,
should
because I'm on the channel.
Yeah, can
But
people
okay.
switch to the French channel
Yes,
to
I can hear you
Chantal?
because I'm on the channel. Okay,
Thank you,
heard
thank you,
that.
Chantal.
Oh, you did, Sbo, sorry.
Is that okay for the speakers? Irene and
Could
Sarah?
she repeat the question again, please?
Yes. So
Irene
digital.
and Tara, would you like to? I just need to say to every attendees that Dong had to leave early. So if you don't, that's why you're not seeing him. He had another engagement, so he did send his apology. Irene or Tara, do you want to respond to the question?
Sure. So I think, yes, the preferred mode of interaction is face-to-face interaction, which is not only good for our mental well-being, but it also ensures that we're not focused on our technologies and our devices to the extent that we're missing out on different relationships and interactions with other people in real life. But I think if you're denied that interaction, and for example when COVID was there, a lot of things shut down and people couldn't leave their homes, then still having a sense of community through these WhatsApp apps, WhatsApp groups and support groups online is still something. So I think we'd encourage people to, of course, meet face-to-face if possible. But if not, then why not make use of the technologies that we have and still have interaction with our peers? So that's what I would say to that question.
Nomtika, would you like to add?
Yes, right on what Tara is saying, actually. I think there's this conversation when it comes to digital technology, and especially where we also highlight the risks, or the benefits, because it almost sounds like there's this drive for people to have to use digital only. And when we are highlighting the risks, it's almost as if it's negating the actual benefits. And these conversations, this type of research is about us, especially as a community, finding that balance, right? What are the pressing risks for people living with HIV, for marginalized communities, when it comes to using digital? other than, I mean, not necessarily not ignoring the fact that there are these benefits that we know that are very obvious. A lot of people do self-testing, for example. People have now introduced, digitized forms of engagement and counseling. People have advocacy spaces, for example, where they can raise issues, report issues in chat rooms. But then there's the aspect, and I think it goes back to the question that someone asked that we hadn't addressed around the fact that Dr. Google is there. Yes, I think Irene started answering that. The idea is technology is there, and it definitely is beneficial, especially to communities. However, there's a strong need for literacy, regulation of some of the risks involved that we need to sort of have a look into, and digital literacy. So if Dr. Google is the first point of contact, how do I get there and ensure that the sites I go to find my information are the accurate ones? How do I filter information? How do I remove my data from a platform if I don't want it there anymore? And I think the conversation is essentially around that. How do we equip ourselves as people, individuals, but also as a community to navigate the digital spaces to get these benefits, but also be mindful of some of the dark sides of it that might actually affect us before we actually find ourselves there.
Irene? Thanks, Tika.
Okay, so just to also add on, when it comes to healthcare provision, it's comprehensive, and we know that the world is changing. We're in a very digitalized world, so everything has changed, particularly with the outbreak of the COVID pandemic, and so a lot of people use digital tools, digital technologies, and health applications to access healthcare services. But that is not to erase the fact that in-person healthcare services are the best. Because if you have an infection, for example, you have an oral infection, you could get all the suggested treatment options from Dr. Google or from any social media application or any health application. But at the end of the day, before you are able to access treatment, you need to avail yourself for examination. And that is what a lot of young people or a lot of people might want to run away from. We cannot run away from these in-person services. Conversely, and this could be because of negative attitudes of some healthcare personnel or the unfriendly nature of youth services when it comes to young people's health. A lot of young people are not really youth friendly, and so a lot of young people find it difficult to go in for these in-person services. But I would encourage every young person you could use all the social media and online healthcare platforms to access healthcare services. But when it comes to care and treatment, including mental health, you would need to be physically present to ensure that you get the maximum benefit of these services. Thank you.
Thank you. And just an additional question, just as Irene, you've taken us to around mental health. There's one question that's asking that, and if all the speakers just could respond, Tika, including you, looking at and considering mental health issues among young people, do you think dependence on the use of smartphone is also healthy?
Can I go first? And I think it kind of alludes to what we're saying now, right? Around digital, good, bad, what is the balance? But I did note this question actually, Taurai, so thank you for raising it. It is a whole other area for us to look at, right? Because as you can see, the common thing from the three countries is that there's this dependence on phones, and the quotes initially during the sessions, we were asking these questions around, is your phone controlling you? Do you feel like you are in control? And it was, these responses were essentially linked to connecting with people, entertainment, and health access, right? So when someone, for example, there was a quote that said, why am I so busy but still feel the need to check my phone? That isn't quite defined, right? Are you checking your phone because maybe you're busy, but you're a peer educator and you don't know if someone you're looking after might ping you? Or are you checking your phone to go on Instagram to a page like Dr. Pong's page, as Dong has shown us, or to to watch your yoga, or feel, frustrated by how other people seem to be doing well? The aspect of mental health came up a lot as a theme to explore in the research, and not something that we've looked into, because if we're to delve into mental health specifically, it's a whole other area, especially for our communities. So just from this particular lens where people have reported using and depending on phones a lot, I think it's an entire area that we still need to explore quite extensively. So it's an opportunity to really expand on this work, but it's definitely something that we've thought about. We've highlighted it as a concern, but we haven't really done enough dense work on this research to ground it more substantively. Thanks.
Thank you. Thanks, Tika. Irene and Tara, do you want to respond, or should we move to the next question?
I think we can move to our next question.
Okay. So just just to close now, I'd like to there was a last question that I'd like the speakers to, just as a closing remark, respond to this question and maybe just give any inputs that you'd like to add. The last question is around fears of being bullied, stigmatized, and people that are close to you getting your secret about your HIV status and issues related to being suicidal. Can any of you tell us the support system in place to help the affected ones?
Online.
Yeah, I think because it came out quite a lot in the research, and I think because it came out quite a lot in terms of like what spaces, if there are any spaces that have been created, and it was also one of my questions around, we see from the data that stigmatization, like, the fears of being bullied, but what kind of like spaces are there, if there's any? I don't know if there's anything that came out from the research. I think that's what the question is asking.
Okay, maybe I'll for now pass it to Tara and Irene in case there's any specific.
Yeah, so I think for our research, we did note that majority of the participants relied on WhatsApp support groups. This is because some of them are actually civil society activists as well. So they did have specific WhatsApp groups that they would talk about specific thematic health issues on. And so I think for us, based on the stigma, discrimination, bullying that a lot of people experienced, they did talk about seeking support from these groups and their fellow peers who may be going through the same things. So I think for us, WhatsApp actually was the key key space for a lot of our participants to seek that support. Yeah, and I hope that answers your question, but there is obviously a need. And I think as one of the recommendations, we did talk about the need for digital safety workshops to find ways to ensure that there are avenues for young people to seek support and also to report some of these breaches and violations of their rights online. So that is something, like Tika said, in addition to mental health issues, areas we'd like to explore about how to hold these people who are abusing other people online accountable, and also ways to create safe spaces for others to share their experiences and get the psychosocial support they may need. And I hope that answers your question.
Thank you, Tara. Irene, do you want to have any additional comments around this question, but also anything around the research too?
Well, Tara has answered perfectly the question. And just to also add that aside having these WhatsApp groups, which are very well in existence and providing these supports for group members who may not be too, active or too vocal, they might reach out to one person in that WhatsApp group for additional informational support to seek redress or to find solace and ensure that they're able to have build resilience and move or progress in life. Thank you, Anoba.
Thank you, Irene. And I'm just going to read Tika's comments, is that for now, most spaces for participants have been platforms that they established themselves, so the legitimacy still sits with the people, as there is a very minimal to no regulation on such occurrences. So innovation paid shared by presenters are kind of the support spaces, as Tara says. And we have come to the end of our interesting conversation, and really it was really great to hear what really came out really from the research. And thank you for joining us. For our networks, it's important to learn the benefits of digital health, but also be intentional about human rights-centered approach to implementing this kind of work. We particularly saw from the research. I must say, I was particularly struck by the insights on the digital divide across geography, gender, and other factors, as well as the need for more digital literacy to improve online navigation and security. So this work is really important, and I thank everybody for joining us today. Thank you.
Big thank you to our ED, Sbo, for holding the session for us. Thank you very much. And thanks to everyone for attending.
Thank you, Tika.